of pediatric surgery. So we have 6 speakers today. We will be starting with our senior consultant, Dr. Nargis Barsiwala. Ma'am is senior consultant pediatric surgery in SRCC hospital, and she is also attached to various other hospitals. She has expertise in neonatal and pediatric surgical care, with special interest including management of high-risk newborns, neonatal surgical condition, and pediatric emergency. So now I will switch to ma'am.
How will we see the slides? Same place. Just a minute, till we Then reason? No. Okay. So I hope everybody can see this screen and the slides. So my topic today is the abdominal duplications in children. It's a very concise topic. And okay. So let us talk about this abdominal duplication in children. Now, once the name duplication comes, we know okay, it is a the gastrointestinal tract. I will be talking only about the abdominal duplications. These are the congenital abnormality where a portion of the gastrointestinal tract develops abnormally, forming a fluid-filled sac which is attached to the intestine. There are mainly 2 types. Classification, we can see it is that so one is cystic and one is tubular. In cystic variety, it forms a fluid-filled cystic sac. And in tubular variety, it is like a tube adjacent to the bowel. Now, it can be found anywhere from the mouth to anus. Most common ones are cystic, as I told you, and they are on the mesenteric aspect of the small or the large intestine. We can see them as multiple cystic duplications in one patient, and it can be both. It can be present in the thorax also, in the abdomen also. This is about in 30% of the cases. So whenever you have treated a child with esophageal duplication, he or she comes with another abdominal symptoms or signs, then please think about the duplication first. Now, you can remove these things. Now, depending upon the organ from where they are arising, we can divide them. Most common is the midgut. Where it is the most common is the ileum. Jejunum is 10%, as you can see in the figure diagram. Then why it is important? Because this midgut duplication, usually they have the ectopic alimentary mucosa, and that is a gastric mucosa. And this gastric mucosa can cause a lot of problems, including peptic ulceration, bleeding, and occasionally perforation. Then there is a colonic duplications. We call it a hindgut duplication also. These may be, usually they are tubular in variety, and a rectal, which is very rare. Now the specific characteristics of the duplication, where you can differentiate them from other cystic lesions in the abdomen. They are lined by alimentary tract mucosa, as I told you. And we see in 20% this ectopic gastric mucosa. As I told you before, these can be cause peptic ulceration and bleeding and occasionally perforation. They have a well-developed coat of smooth muscle. So they are thick-walled cysts. They are not very thin-walled like other cystic lesions we see. And they usually share the wall and the blood supply with the adjacent organ or the bowel with which it is intimately attached. Cystic variety usually are not communicating with the gut. That's why they are cystic, because the fluid gets collected inside, it doesn't drain into the alimentary tract, and they form a cystic lesion. While the tubular duplication, so many times are communicating with the gut. Embryology, exact embryology, we don't know. And it is thought that the cystic variety develops because of the cord, and it may be associated with spinal cord or vertebral anomalies. Tubular ones are supposed to be because of the partial twinning. Because of this embryology, we see a lot of associated anomalies. The cystic is usually associated with vertebral or the spinal cord anomalies because it is a split notochord, and notochord is the vertebral and the spinal cord develops from it. We see sometimes malrotation or atresia in case of midgut duplication. Then anorectal and genitourinary duplications are seen with the hindgut lesions, and tubular ones are associated with urinary tract, spine, and the central nervous system. How did the child come to? Usually these children are diagnosed before the 2 years of age because these duplications are usually symptomatic, and in most of 50% of the children, you diagnose them before the 5 months of age. It is a disease of the infancy. It's very rarely asymptomatic, and very rarely it's as a coincidental finding. You find it when you are investigating the child for some other disease. They usually present the mass in the abdomen, distension of abdomen. This mass in the abdomen will be related to the size and location of the cyst. Intestinal obstruction. Obstruction may be because of the mass effect. It causes compression because of that cystic mass, or it may be because of the torsion of the cystic duplication. And if it's a very small cystic thing, it causes sometimes interstitial, and a child will present to you with intestinal obstruction. They will have all the signs of intestinal obstruction, that is vomiting, pain in the abdomen, distension of abdomen, visible bowel loops, and not passing stool for 2-3 days. Abdominal pain. It is so many times acute. An acute variety is basically because of that duplication. Sometimes a child will have a chronic severe abdominal pain, and this is because of the gastric mucosa causing peptic ulceration. The same reason why there is blood in stool also. Antenatal sonography is very important. The parents will come for your counseling. If antenatal on sonography, somebody has told them there is a cystic mass in the abdomen. There are a lot of other differential diagnoses. We have to counsel them at that time. Okay, we'll look after once the child is born. Once the child is born, we can do the sonography and see what kind of cyst we are suspecting. If symptom is and less than 4 centimeters above the child and follow up properly. More than 4 centimeters are causing some symptoms, then according to investigate. As I told you, antenatal, sometimes the parents come with a cystic lesion in the fetus, abdomen of the fetus. At that time, you counsel the parents properly. If it is a treatable disease and not to worry about it, whatever kind of cystic lesion it is, that we will have to take care of it once the child is born. Otherwise, USG sonography abdomen is the gold standard. It will show you a cystic mass. Depending upon the position and location of the cystic mass, you can decide from which organ it is arising and what kind of cyst it is. X-ray abdomen also may help you in diagnosing. Whenever there is an obstructed abdomen, it will tell you that this is an obstructed abdomen. And some of the cysts are so huge that you will be able to see them. Anteriorly, if it is there, then you can suspect it is an omental cyst, or it is in the middle of the abdomen. Then you can say, okay, this may be a midgut duplication. CT or MRI is very rarely required, but it is required when you want to confirm from which organ it is arising. These are the basic differential diagnosis. I will show you the slide, so you will come to know how to differentiate between these cystic lesions in the abdomen, these mesenteric cyst. This is mainly a very thin wall cyst. You can see that thin wall, and there is a chylous fluid or a serous fluid inside. So that way you can differentiate between the duplication and the lymphatic cyst or the mesenteric cyst when you are doing the surgery. Now, this is an omental cyst. See that CT where it is showing that cyst is entirely in the anterior abdomen. And this is the way it looks like. The omentum is almost necrosed because of that cyst which is started inside. This is an ovarian cyst, which will be easy to diagnose. Even on sonography and even on clinical palpation also, you can make it out, the ovaries going up to the pelvis. This is a meconium cyst. It is a newborn disease. There will be abdominal distension, then red colored abdominal skin, bilious aspiration or bilious vomiting. I'm showing you all these slides so that when you see this duplication cyst, you will realize how different it looks like. This is a cystic duplication cyst. You can see the wall. It's very thick wall compared to what I have shown you in the previous cyst. And here it is apparently rotated, and that's why there is an intestinal obstruction. See, these are the dilated loops, which are proximal loops, and the collapse. Here it shares the wall of the.
मैंने डबल सनग्लासेस लगा के खींचे
But he's speaking.
दिख रही है डबल
This is a gastric duplication. It is like it's not as round as you saw it in the midgut duplication cyst, but this is a cyst there inside, which was shown in sonography also, and we had done CT also. This was a child about 1 month of age, and the child was having exact picture of hypertrophic pyloric stenosis, that is a vomiting which was non-bilious. When we did sonography, instead of a pyloric tumor, there was a cyst. And we had to differentiate between the choledochal cyst because it was just below the liver. So we had done the CT, and then we came to know, no, this is a gastric duplication. This is another gastric duplication. This is at the antrum, and it is supposed to be very, very rare. Gastric antral duplication, when I searched in the literature, it was not found even. Now, how will you treat the child with this gastric duplication? Once the diagnosis is confirmed, there is only one treatment, and that is removal of this cystic lesion. If it's a midgut or cystic duplication where you can do the resection and anastomosis, that is the best way of removing this cystic mass. So many times it is not possible due to its location and the bowel involved. Just like that gastric antral duplication. I couldn't excise the cyst along with the antrum. So we had done a partial excision. That is whatever wall we could excise, we have excised it. And then the marsupialization, the strip of the mucosa. So once the mucosa is removed, then the problems of secretions, peptic ulcerations, everything is over. Long tubular duplications are very rare as compared to cystic variety, which is quite common. It's not very rare, but the tubular duplications are very rare. It is like a second parallel tube. It is often connected to the bowel. It shares that supply also. So if you see it, you so many times don't differentiate between which one is the normal tube and where is that duplication tube, and you will see some thickening over there. The complications are because of obstruction, pain because of the gastric mucosa, which causes the problem, and a bleeding also because of the peptic ulceration. The diagnosis is usually difficult and often made during surgery. Sometimes the child comes with pain in the abdomen. We do diagnostic laparoscopy because we have not found anything on every investigations. We were just struggling to find what is the reason. You do a diagnostic laparoscopy and you see that there is a tubular duplication. This is how it looks. See that intestine periphery, and there is a tube parallel, but you can't make out the separating wall exactly. Once you are aware of okay, this is a tube there, then you can see it. Here, the tubular duplication was so long that I have done partially resection anastomosis, and at the other half of the tubular duplication, I have put multiple incisions and removed the mucosa as a tube from inside. So in concise, the treatment is excision of the involved segment with resection anastomosis. In case of a very long tubular duplication, where remaining length of the intestine may be a concern, the management becomes tricky. There you do submucosal resection, where mucosal lining is stripped using multiple incisions in the seromuscular wall. In case of a colonic duplication, if proximal end is connected, causing a cyst, then one can make a distal anastomosis also. So it drains off the fluid that is collected in that tubular duplication. But it's better to remove the mucosa because sometimes this peptic mucosa may cause a problem. In conclusion, cystic duplications are not so uncommon. Not very common. Treated, the outcome is good. Associated anomalies have a significant impact on the outcome. And tubular duplications are quite rare. They are difficult to diagnose and still difficult to treat. So the takeaway message will be, if any child comes with a mass in the lesion in the abdomen, then please suspect the duplication and other cysts also. And a diagnosis by the sonography is gold standard. You see that cystic lesion, and then if further you want to differentiate, we can do the CT or the M. Thank you. Thank you so much. Did they ask any questions? Fifteen minutes. 20 minutes.
Good afternoon, everyone. So I'll be speaking on the topic laparoscopic management of GER and Achalasia Cardia. Gastroesophageal reflux is physiological and it involves involuntary passage of gastric contents into esophagus.
Yes.
So gastroesophageal reflux is physiological, involuntary passage of gastric content into esophagus with or without visible regurgitation. So GERD is considered to be pathological form of GER, resulting in symptoms which can lead to morbidities and even fatal complications. Infants and children are mostly susceptible to this pathological GER, and this physiological GER normally it's self-limiting and it limits within 2 years of age. However, symptoms in older children tend to be chronic, waxing and waning like an adult pattern. Coming to pathophysiology of GER. So whenever esophagus is comes in contact with the acid reflux, multiple erosions happen. So esophageal defense consists of 3 tiers. The first one is anti-reflux barrier consisting of lower esophageal sphincter, diaphragmatic pincock, and angle of His, esophageal clearance, and esophageal mucosal resistance. So intra-abdominal esophagus, it consists of right and left crust of diaphragm, which produces a pinch cock action to constrict esophagus at the hiatus. You can see it here. The length of the intra-abdominal esophagus should be equal to or more than 2 centimeter, and the angle of his should be acute. It is an acute angle between the greater curvature of the stomach and the esophagus. If this angle is obtuse, as in hiatus hernia, GER episodes can occur. So lower esophageal sphincter consists of inner circular muscles and outer longitudinal muscles. This extends towards the greater curvature, and it is a high pressure zone with length of 3 to 6 centimeter and pressure of about 20 millimeters of mercury. So whenever pressure less than 6 millimeter mercury favors GER, and 20% occur in relation to decreased basal lower esophageal pressure. So it is supported by, so lower esophageal sphincter is supported by crura of diaphragm at gastroesophageal junction together with valve-like function of esophagogastric junction. They form anti-reflux barrier. So another term is transient relaxation of the lower esophageal sphincter. So this is defined as abrupt, prolonged, that is more than 10 seconds, and incomplete relaxation of lower esophageal sphincter. It occurs independent of swallowing and is most frequent mechanism causing GER in children and adults. So the reasons of failure of this barrier of GER and occurrence of GERD are as follows. It can occur due to malposition of lower esophageal sphincter, that is, the pressure decreases below 6 millimeters of mercury. The length of the lower esophageal sphincter is less than 2 centimeter. Abdominal length is less than 1 centimeter. And there is abnormal smooth muscle function. So intra-abdominal esophageal length, whenever it's shorter, that is less than 3 centimeter, GERD occurs. Angle of his is obtuse here, and there is poor smooth muscle function in these cases. So this is the chart showing the causes. So here we can see abnormal relaxation, laxity of sphincter, causing GER. Also, hiatus hernia increases the chances of GER, and there is poor mucosal resistance and delayed acid clearance are other causes. So these complications of GER includes erosive esophagitis, stricture Barrett's esophagus, which is the change of squamous into columnar epithelium, and failure to thrive, progressive pulmonary symptoms, and adenoidal enlargement. So risk factors of GER in infant and children are as follows. In infants, prematurity and post-op cases of esophageal atresia, diaphragmatic hernia, neurological impairment, abdominal wall defects such as gastroschisis and omphalocele can result into pathological GER. In children, neurological impairment, hiatus hernia, post-anesthesia treatment results in GER. So symptoms of GERD will be, these are most often directly related to the consequence of vomiting, poor weight gain, and results from exposure of esophageal epithelium to the gastric content. Typical symptoms which are seen in adults like heartburn and regurgitation are not readily seen in infants and children. Most of them will come with complaints of cry and sleep disturbance and decreased appetite. So these are all the clinical symptoms. So typical features will be in infant will be regurgitation, irritability during the feed, refusal of feed, inconsolable crying, and atypical features include apnea, stridor, hoarseness, hematemesis, and Sandifer syndrome, which is posturing with opisthotonus or torticollis. So clinical features in children mimic that of adults with nausea with or without vomiting, pain abdomen, heartburn, drooling or water brash, or choking during feeding or night, and poor appetite. So these all lead to some non-GI manifestations, such as, so it can also mimic pulmonary disease like asthma and recurrent pneumonias. So, and other extraesophageal symptoms will be similar to chronic otitis media, persistent cough. So diagnosis depend on the type of clinical, so the diagnostic investigation depend on the type of clinical manifestation. A thorough history and clinical examination has a reliability of 60 to 70%. Whenever typical symptoms are present, we can one can go ahead with upper GI contrast study or endoscopy. Some tests like pH and multi-channel channel intraluminal impedance can be a choice in cases of atypical symptom or after failure of empirical therapy. So whenever history of child, history of child is important. So one should always make sure to ask about feeding and dietary history, pattern of vomiting, medical history, family psychosocial history. And so the diagnostic tests aim at documenting the presence of pathological reflux or its complication. So it is important in evaluating the therapy and excluding other conditions. It helps in documenting tissue damage and documenting the anatomical defect. Barium contrast radiography, it helps in direct visualization of esophageal mucosa and assessing the function of lower esophageal sphincter, and it evaluates the esophageal clearance. It also evaluates strictures, stenosis, hernia, gastric outlet obstruction, and it has advantage that it detects all the anatomical abnormalities. Also, this contrast study can also rule out distal obstruction at the same time. So malrotation can and causes like duodenal web can be excluded simultaneously. So limitations are that it cannot discriminate between physiological and non-physiological GER episode. And in children with recurrent aspiration, video fluoroscopy studies are recommended. So radionuclide scintigraphy or milk scan using technetium can demonstrate aspiration and delayed gastric emptying whenever it is suspected. So endoscopy along with biopsy can diagnose features of esophagitis and also complications of GER such as strictures or Barrett's esophagus. It is also therapeutically helpful in dilating the strictured esophagus. The only limitation is need of sedation or anesthesia, and it is not useful for extraesophageal GERD. So similarly, esophageal pH monitoring, it is not always done. It helps in assessing efficacy of acid suppression during treatment and evaluating apneic episode in conjugation with pneumogram. And so it has advantage that it detects the episodes of reflux and determines the effectiveness of esophageal clearance mechanism and adequacy of H2 blocker and PPI in unresponsive patients. But it has this esophageal manometry, now coming to esophageal manometry, it has poor specificity and sensitivity in diagnosis of GERD. It is useful to rule out esophageal motility disorders during preoperative evaluation. It also helps in diagnosing achalasia, wherein the symptoms mimic that of GERD. So these are the treatment goals: elimination of symptoms, prevention of relapse, management or prevention of complications. Management can be medical management, where lifestyle modification and dietary modifications such as in changing the volume and frequency of feed helps with the GER symptoms. Thickening of feed is another method. So pharmacological therapy includes H2 blockers and proton pump inhibitors, antacids, prokinetic agents, surface agents. But evidence available so far does not support the use of PPIs for infants with unexplained crying or distress. There's no role of PPI in extraesophageal symptoms. Empirical therapy recommended is around 2 to 4 weeks in uninvestigated GERD symptoms. For partial responders, this twice daily dose can be given, but in non-responders, investigation should be carried out within 4 weeks of therapy to rule out other causes. There is no difference in efficacy between various available PPIs. Surgical treatment, it is necessary only when medical management is unsuccessful. And surgery should be considered when GERD is related to acute life-threatening events, aspiration pneumonia, failure to thrive. Whenever there is troublesome symptoms despite adequate medical therapy and persistent vomiting or severe symptoms refractory to medical therapy, surgical treatment should be considered. So this is similar criteria and guideline which was given by European Association of Endoscopic Surgery. So surgery is relatively contraindicated in severe cardiac or pulmonary disease, scoliosis, and in cases of prior abdominal surgery. So anti-reflux surgery has advantage that it corrects underlying pathophysiology and controls all types of reflux. It removes the lifestyle restriction, and also the only disadvantage is that recurrence is possible. So anti-reflux surgery is the way of creating mechanical anti-reflux barrier. It is effective against different types of reflux. It is curative in 87% at 5 years and 72% at 10 years. So fundoplication always includes hiatal reconstruction and restoration of adequate length of intra-abdominal esophagus. The valve which is created around esophagogastric junction should be floppy, and it restores the angle of His. It increases the lower esophageal sphincter basal pressure, decreases the transient relaxation of lower esophageal sphincter, and decreases the capacity of gastric fundus, thereby speeding the gastric empty. So it it has various advantages over the open surgery because they are good because of good access to hiatus, esophagus, and stomach. Uh, the surgery is better, and it minimizes the surgery. It is cosmetically better, and the symptoms like respiratory depression due to pain or post-operative adhesions are lesser here. So fundoplication, which by definition means wrapping of fundus around the lower portion of esophagus. It can be a complete wrap or a partial wrap, like thal fundoplication or toothpick fundoplication. Sometimes it is combined with gastrostomy. So these are the two major type of fundoplication. So laparoscopic Nissen fundoplication is proven very effective in controlling reflux over a long period of time. And currently surgeons should the surgical objectives here are ensuring an intra-abdominal esophagus and creating an acute angle at gastroesophageal junction and creating a high pressure zone around the lower esophagus. So this is the position. This is a picture showing the position of surgeon and the assistant. The infant and young children are positioned at foot end of the bed in a frog-leg position, and monitor is positioned at the head end. And uh, patient is kept in reverse Trendelenburg position so that intestine fall away from the operating field. The surgeon stands at the foot end with the assistant on the right hand side. So these are the position of the ports. After placement of umbilical port, two working ports can be placed on both the sides. Here, the epigastric port site is used for placing liver Nathanson retractor. And otherwise, the second option is to place a retractor with locking grasping forceps, a locking grasping forceps secured onto right crus of diaphragm. If gastroscopy button is to be placed, a spot in abdomen is identified prior to the insufflation, and this serves as the right handmost working port. So this is the video of laparoscopic fundoplication. So here we didn't use the liver retractors like three-prong retractor and Nathanson retractor. Instead, we used a Vicryl suture which hitches the abdominal wall to the to the peritoneum left lower lobe near the gastroesophageal junction. So this keeps the left lobe of liver retracted, showing the esophagus, proximal esophagus, and the gastroesophageal junction. So here the dissection is carried out. This is the zona pellucida of lesser omentum. Slowly the dissection is carried out using hook cautery. Meanwhile, small cells which come along can be cauterized. The dissection is started on the right hand side of the esophagus. So this zona pellucida of lesser omentum overlies caudate lobe of liver. So a grasper. So now the retroesophageal window has been created. We are able to see right crus of diaphragm. On the opposite side will be the left crus. So now the hiatal anatomy is visible. Both the crus are sutured together to limit this hiatal window. We have used Ethibond 30 sutures here. So, also, while suturing these two crusts of diaphragm, some prefer taking a bite can be taken along the posterior wall of esophagus also. One should make sure that the window is closed. The posterior vagus, which runs along the esophagus, has to be secured. So now the tightening of hiatus has been done. So exposure of gastroesophageal junction and flush is complete now. So here the fundus of the stomach has been taken through the window. Now the wrap, which is 360-degree complete wrap, is created by using Ethibond sutures. So the first bite of suture, which is taken, should also take a bite of esophagus, upper esophagus, or sometimes diaphragm can be included in this suture. About 3 to 4 sutures can be placed. Suturing is completed. The wrap should not be very tight. A floppy wrap is preferable. Vagus has to be preserved. Also, while mobilizing lower esophagus during creation of this intra-abdominal length, avoid injuring the pleura and also underlying major vessels such as aorta, which runs behind this. Now we can see that the second layer of suturing, second suture has been taken. So gastrostomy can be also performed after this. So lap fundoplication. So thal fundoplication is 180 to 270-degree anterior wrap. Basic dissection is similar, only that one should not create a posterior window here, and it achieves the same surgical objective as other types of fundoplication. However, it has higher failure rate in neurologically impaired children when compared with Nissen's fundoplication. It is preferred in abnormal esophageal length or abnormal motility. So this is how it is done. First, the suturing of fundus to the left side of esophagus is done, and then the wrap is created by suturing the top of the fundus to the top of the intra-abdominal esophagus in the similar way. And the second row of sutures are later placed along the line of first row. This is how the final view of anterior wrap happens. So this is the fundus. You can see the anterior wrap here. So this is Tupi fundoplication, which is posterior partial wrap. Here sutures are placed on the left and right side of the esophagus to secure it to the diaphragm, and then the fundus is passed behind. You can see this is the fundus, which is passed behind the esophagus and positioned for the wrap. The left side is sutured initially along this side with a line of 3 sutures, which is tied intracorporally. And then a 270-degree wrap is complete with left side suturing. This is the left side suturing, and is checked for tightness. So outcomes are immediate and complete heartburn control is seen in 90% of the patient. It provides excellent relief of regurgitation and respiratory symptoms. It's very effective response to response of postural and nocturnal symptoms. there is improvement of quality of life, and there is decreased incidence of malignant transformation in long term. So complications will be most common complaint post fundoplication is dysphagia because of tightness of the wrap. It is speculated that division of short gastric vessels permit the creation of relatively loose fundoplication, but this is not commonly done. And slip lesions that occur as a result of crural breakdown and migration of wrap into the chest to resulting into hiatal hernia. So recurrent GR disease is the most common problem after fundoplication. Majority of reoperations are performed within 12 months after the initial operation. So these are the complications of the full wrap. Lesser complications are seen with partial wrap. So other side effects are gas clots syndrome. So revision surgery for anatomical problem with fundoplication or hiatus. Laparoscopic reoperation is viable and safe. So Nissan's a complete wrap is preferred. Now coming to achalasia cardia. So it is a Greek term which means does not relax. The act of swallowing normally initiates a peristaltic wave, which propels the ingested material down the esophagus. So deglutition also triggers relaxation of lower esophageal sphincter that allows the swallowed material to enter the stomach. But this poor lower esophageal contraction in achalasia results into functional obstruction of the esophagus and resulting in increased pressure due to retained material, which generated by the sphincter muscles. So clinical manifestations include dysphagia for solids and liquids. Although dysphagia for liquids can occur in patients with other mortality disorders, symptoms is most characteristics of achalasia and strongly suggests the diagnosis. Barium swallow is the primary screening test. We can see the beaking of the contrast here. Diagnostic accuracy is approximately 95%. In some cases, dilation is so profound that the esophagus assume a sigmoid shape. Other tests include manometric evaluation for confirmation in virtually all cases. Relative risk, there is elevated resting lower esophageal sphincter pressure. Incomplete lower esophageal sphincter relaxation also happens. So there are three types of achalasia, which was as per manometric study. So type 1 is classical and there is no pressurization in the body of esophagus. Type 2, where there is increased pressure in the body of the esophagus. And third, type 3 is spastic achalasia, where there is increased pressure in the body of esophagus, but it obliterates the lumen. So type 2 is said to have the best results with surgery. Endoscopic evaluation is done to exclude malignancy at the esophagogastric junction, and so findings will be in endoscopy could be normal, or there can be tight lower esophageal sphincter, dilated sigmoid esophagus with retained food and saliva. So it is recommended for people with symptoms where there is excessive weight loss in relation to duration of symptom or difficult passage of endoscope through the gastroesophageal junction. Medical therapy, calcium channel blockers and nitrates have limited use because of its side effects. So dilatation of lower esophageal sphincter provides excellent short-term results. But approximately 50% of the patients will require further therapy within 5 years. Esophageal perforation is the most common symptom. In children, results are not good, and always surgery is advised. Endoscopic injection of Botox. It is a daycare procedure. 20 to 25 units of in each quadrant is injected in lower esophageal sphincter. Effect takes 1 to 3 days and lasts for 3 to 9 months. The side effect is retrosternal pain. POEM or per oral endoscopic myotomy. mucosal incision 6 to 10 centimeter proximal to lower esophageal sphincter is made. Dilation and dissection of submucosal plane using air or CO2 is done, and division of circular fibers here is done, leaving longitudinal fibers intact. The procedure takes around 1 to 3 hours. Side effects are subcutaneous emphysema, pneumothorax, segmental collapse. It is laparoscopic surgery post-poem is little bit difficult to perform. It is a highly skilled procedure. Coming to surgical myotomy via modified Hiller's approach result in good and excellent relief of symptoms. The lower esophageal sphincter is weakened by cutting its muscle fiber. The circular and longitudinal muscle fibers are divided, and the myotomy extends 6 to 8 centimeter on esophagus and around 1.5 to 3 centimeter on gastric side. And at the end, fundoplication is that is door or toupee fundoplication is done to reduce the reflux. This is how the myotomy is done. Laparoscopic cardiomyotomy is combined with door fundoplication. So door is preferred initial approach of choice, and it provides symptomatic relief of dysphagia and food regurgitation. Contraindication are extensive adhesions due to previous abdominal surgery. Intraoperative endoscopy simultaneously may help to identify the cardia during during the surgery, and endoscopically placed balloon dilator can be used to distend the stomach and facilitate the division of residual muscle fiber. It also helps in testing the occult mucosal perforation. This is the position of the patient. This position is similar to as we did in fundoplication. The monitor position and the position of the surgeon is same. Port position similar. So umbilical port is used for placement of camera. Working ports in mid-clavicular line on both the side. Liver retractor is placed from the rightmost port position, and stomach retraction can be done by anterior axillary line. So these are different types of instrument used for liver retraction. These are the steps. The first is to dissect the hiatus and expose 4 to 5 centimeter of esophagus. Then the extension of this incision towards the gastric side is done. At last, door fundoplication is done. So extensive dissection at esophagogastric junction is avoided because it could result postoperative GER. And this is how it is done. Retraction is done. Then this is anterior dissection is done. So this is the dissection being carried out near the gastroesophageal junction. So here we have used hook cautery. We can see the lower esophagus. So the area of myotomy is marked using hook cautery, and the circular muscles are separated using Maryland forceps along the till there is mucosal bulge. This is how it is. And now door fundoplication is being done. I had explained about the door fundoplication in the previous slide. Move ahead. So post-operatively, patient can be given clear liquids in the evening Complications are mucosal perforation. And if there is any intraoperative mucosal perforation, it can be sutured using 50 Michael. Complications are incomplete myotomy, which will need redo surgery. Sometimes in long term, they may need esophageal replacement surgeries. Prognosis, type 1 has intermediate prognosis, type 2 has better prognosis, and type 3 is the least favorable one. So, thank you. Our next presenter is Dr. Sarita Bhagwat ma'am. She is consultant pediatric surgeon in SRCC. She has expertise in neonatal surgeries. Her topic will be neonatal intestinal obstruction.
Good afternoon, everyone. I'll be talking about neonatal intestinal obstructions. Slides not moving. Slides not moving. So on an average, if you see the surgical admissions in NICU, 25 to 30% of them are due to neonatal intestinal obstructions. They can be classified as organic or mechanical obstructions and functional or adynamic obstructions like paralytic ideas, necrotizing enterocolitis, or Hirschsprung's disease. So going through the list of causes of neonatal intestinal obstruction, in the wall there will be atrasias. Lots of atrasias are there, duodenal, ileal, jejunal atrasias. Some occasionally, once in a while, we do get colonic atrasias. Outside the wall, there can be bands, like in a baby who has malrotation can develop intestinal obstruction due to Ladd's bands that results into volvulus intermittently. Whenever there is volvulus, child will have bilious vomiting. Other kinds of adhesions that we see in newborns is because of meconium peritonitis. There is a leak of meconium in the intrauterine light that results into adhesions. And these babies usually present very early after the birth, within few hours. We'll talk about the details in a while. Other kinds of adhesions are remnants of the vitalointestinal ducts and the vitelline vessels. If a loop of bowel goes under it, or the loop of bowel just goes round the VI duct remnant. Duplication cysts, Dr. Nargis has already covered. A kind of meconium peritonitis is giant cystic meconium peritonitis. We'll see one case about that. In the lumen, we can have meconium plug syndrome. It may or may not be associated with cystic fibrosis. Meconium ileus, where there is obturation of meconium in the terminal ileum. Milk inspission or formula inspission. Then other causes of neonatal intestinal obstructions are obstructed hernias and very rarely a missed anorectal malformation. There can be functional obstructions like, premature, lot of prematurity and no birth weight babies. They will take a little while to settle and go on feeds. Some of them can manifest as paralytic ileus because of sepsis. Few of them will result into necrotizing enterocolitis. And Hirschsprung's disease is also one of the causes of functional intestinal obstruction. Depending on the length of the segment involved in aganglionosis, they may present very early also in newborn period. So to talk about the physiology of neonatal intestinal obstruction, because of abdominal distension, it results into abdominal distension. The proximal to the obstruction, there will be distension. You can see on the X-ray air fluid levels. So this fluid is in the third space. It is outside the circulation, and this third space can give rise to dehydration. Okay, if untreated, it can result into hypotension and shock. Also, because of abdominal distension, there can be diaphragmatic movements are impaired. Vomiting will be the second most common manifestation. Vomiting depends on where is the level of obstruction. Initially, it will be gastric, later on, it will be bilious. Because of loss of fluids and electrolytes, the dehydration will be associated with electrolyte disturbances. During vomiting in the newborn, there is a risk of aspiration and pneumonitis. And both these contribute, the diaphragmatic impaired movements as well as the aspiration can result into respiratory complications. Now, in cases where because of ischemia, the segment of bowel is not moving, it has compromised blood supply, and it can result into a perforation or a large segment which involves gangrene. This will result into peritonitis. All these add on to shock, poor tissue perfusion, and metabolic acidosis, and this will manifest as tachycardia, hypotension, capillary refill time is increased, and motile baby. We'll go in the common manifestations in the history. We should ask about abdominal distension, vomiting, kind of vomiting, bilious or gastric, failure to pass meconium or stool, or when did the baby last pass urine. So you get some idea about hydration of the baby. In this baby, you can see there is a lot of abdominal distension. You can see visible bowel loops. Urine bag is put there so that we come to know when the baby passes urine. Investigations, air is the best contrast. So plain X-ray abdomen erect, or if the baby is very, very unstable, then the right or left decubitus gives lot of information. Ultrasound will tell us about free fluid in the abdomen, about also about intramural gas in a loop of bowel in NEC, or portal gas. Contrast enema is occasionally required in cases like Hirschsprung's disease, like this baby, in which you can see baby has delayed passage of meconium till day 3 of life. Baby has not passed meconium. There is distension and dilated bowel loops. So a contrast study has been done, and you can see a coning in the splenic flexure, suggestive of aganglionosis of the rectum, sigmoid, and descending colon. And there is coning, and the ganglionic bowel is there from transverse colon and splenic flexure onwards. Very rarely we will do MRI, but that's a reserved investigation. So management is, do remember, whenever you are transferring a baby to any NICU, please send mother's blood sample for grouping and cross-matching, because usually cross-matching of the baby for giving blood to the baby or blood products, cross-matching is with the mother's blood, as the antibodies of mothers are there in the circulation of the baby. So initial management starts with nil by mouth, gastric decompression by nasogastric or orogastric tube, IV fluids, X-ray vertical if the baby is stable, otherwise decubitus, and surgery. We'll discuss few of the cases. So this is a case of, this is a newborn transferred soon after birth. Antenatally, it was detected as double bubble and duodenal atresia. Whenever you have a antenatally detected duodenal atresia, it is a very early embryonic event and associated with trisomies and other things. So usually chorion villus biopsy or amniocentesis is required. Remember that the non-invasive test from the peripheral blood of the mother, it has low sensitivity and best will be to have a chorion villus biopsy or amniocentesis. So this baby was found to have a normal karyotype on investigations in the fetal life, and soon after the birth, the baby was transferred as a duodenal atresia. And you can see a double bubble there. Single bubble is seen because of lot of fluid in the filling the proximal part of the duodenum and the stomach. If you aspirate and inject air or other contrast, you can see that stomach is getting delineated, first part of the duodenum is getting delineated, and beyond that there is nothing going down. There is no gas also distally. So associated with duodenal atresia, you can have cardiac anomalies, tracheoesophageal fistula occasionally, anorectal malformations. Investigation wise, blood is cross match. Investigations like electrolytes, CBC, CRP, X-ray, 2D echo, and surgery will be duodenostomy. This is a late presenting baby who came on after 21 days. That is the third week of life. Baby was doing well or was on full feeds and then suddenly developed bilious vomiting. Now you can see in this X-ray, there is minimal upper GI, upper abdominal distension, and there are two air fluid levels, one in the stomach and one in the duodenum. Distally, there is little bit of gas. So this suggests that this is a obstruction which has developed at 3 weeks of life, and there is distal gas, so this is not a complete one. So differentials will be either volvulus because of malrotation, and that can be detected even on sonography where the superior mesenteric vein and artery axis is changed during volvulus. The other differential can be a duodenal diaphragm with a central hole which is manifesting, and the third one is a annular pancreas. So this is a dye study which shows a dilated stomach and first part of the duodenum. It is like a windsock and almost reaching the third part. Okay, so this baby was operated and had an uneventful recovery. So remember, malrotation with volvulus is a surgical emergency. Usually diagnosis, as I said, is by ultrasound, but it should be referred as early as possible. So there will be bilious vomiting with or without distension. Late, if the baby is not sent early, then there can be bleeding per rectally because of compromise of the blood supply to the entire midgut, that is from the duodenum till almost mid transverse. Okay, so this dye study shows that the dye, there is distally gas, so it is not a complete one, and stomach gets delineated with the dye. Then there is a duodenum, and at the superior mesenteric axis there is entire midgut rotates. So the blood supply to the entire midgut, which is supplied by the superior mesenteric artery, is compromised. And if it is not operated early, then it results into ischemia of the entire midgut, and then there will be bleeding rectally. It is a surgical emergency and should be operated as early as possible. So this baby one of these babies has developed an entire gangrene of the midgut, and this results into short gut syndrome because the entire jejunum, ileum, part of the colon is becoming into gangrene. This is another case presented on day 2 of life with abdominal distension, bilious vomiting. This baby has passed only a speck of very discolored grayish color meconium and thereafter not passed. You can see abdomen is distended and there are visible dilated loops. Here we can see that this is a type of atresia. The proximal part is full and it is all dilated, and distally it is all collapsed. This is type 1 atresia. We'll talk about the types of the atresia. In type 1, there is no rent in the mesentery, but there is part of the atretic membrane is there separating the dilated proximal and the collapsed distal one. In type 2, there is still no rent in the mesentery, but the dilated proximal and collapsed distal is separated by a string of fibrotic tissue or band. Type 3 is divided into 3A and B. In 3A, which is a less severe one, there is a gap in the mesentery, whereas 3B results usually in a jejunal atresia, and the vascular insult is so great that all the supply to the most of the small bowel goes off, and it is supplied in a retrograde fashion by a ileophonic or terminal ileal branch, and hence the intestine gets curled onto this branch which is supplying. This results into Christmas tree or apple peel kind of abnormality. Imagine the plight of the surgeon who has to anastomose this dilated part to the narrow distal part. The minute there is change in the of position, this vascular compromise is very common. And these are the patients which are where the anastomosis is very precarious as far as blood supply is concerned. Type 4 atresia is multiple atresias, and all the atretic segments either have to be joined to each other, or if it is limited segment, then it can be discarded. So this is a intro picture of, as I told you, 3B atresia. It is like an apple peel or Christmas tree. Then we move on to meconium peritonitis. Many of these are antenatally diagnosed as calcifications are found in the baby's abdomen during fetal ultrasound. These calcifications may be localized to one segment if it has resulted into a small perforation which is sealed off and results into meconium cyst, or it can be a very massive perforation where the entire greater sac becomes a big giant cyst. How do you identify big giant cysts? Post-birth, these babies, as I told you in the beginning, they manifest very soon after the birth, and there will be a large air fluid level which cuts across more than half of the abdomen, suggestive that it is a giant cystic meconium peritonitis. There is distension, and I've put a slide of intra photo where as soon as you open the abdomen, you can see this thing studded, the cyst wall, which is studded with calcification, and you can't see any intestine. You have to enter the cyst, and on the posterior wall of the cyst, all the intestinal loops will be found. So depending upon how is the general condition of the baby, how much is the contamination, and what is the condition of the bowel, most of these babies will require a stoma as an intermediate thing. And once the abdominal cavity settles down in few weeks' time, then the surgeon goes in again to close the stoma. Now this is a case of meconium ileus, where the baby has got distension of abdomen and fails to pass any meconium. There are dilated loops which are visible on the abdomen, but when you take a erect or standing X-ray of the baby, there are no air fluid levels. It is only gas. So why the air fluid level doesn't form is because the meconium is so thick and viscid that it doesn't settle down in the lower part to give you a air fluid level. So in such babies, diagnosis is by doing a diagnostic enema with contrast or barium, and you can see the entire colon is microcolon, and this inspissated meconium is blocking the entire terminal ileum as in this picture. And during intra, we do an intraotomy to evacuate all this. It can be treated conservatively by giving washes, either with using normal saline, warm normal saline, or you can use N-acetylcysteine, which is diluted, but you have to monitor the baby during this procedure because it results into a lot of fluid fluxes, and the vascularity of the bowel is also compromised because of a lot of fluids going across the membranes. Few of the babies where it has got meconium ileus has got complicated, we may have to operate and do a stoma. So in this baby, endotomy has been done, And you can see the meconium is so thick that the forceps is standing in that. It's got stuck to that meconium and it can't any longer move also. So it is because of enzymatic deficiency of pancreatic exocrine enzymes. 10% of these babies are associated with cystic fibrosis, so definitely it requires genetic workup to know whether the baby is suffering from cystic fibrosis, and those who have, their lungs have to be taken care of in the perioperative period. Orally, after the surgery, we keep these babies on exocrine pancreatic supplements. Now, this one is a antenatally detected intra-abdominal cyst in a fetus, and the baby was delivered, and baby was on full feeds, and a lump was palpable in the abdomen. On ultrasound of the abdomen, you could see a gut signature sign. The wall of the intestine has mucosa, submucosa, muscularis, muscle layer. So this gives a gut signature sign on ultrasound, and this sign was picked up on this in this cyst, and hence it was detected to have a duplication cyst and not a other ovarian or other kind of cyst. So this baby was operated, and it is on the mesenteric side of the ileum, and part of the ileum was resected with the cyst, and resection anastomosis was done. Baby had an uneventful recovery. Some of the cases of intestinal obstruction can be because of obstructed hernia. On the right, you can see a small boy with a inguinal hernia obstructed, whereas this is a small baby girl where there is obstructed left inguinal hernia, and you can see some redness suggestive of triangulation. Okay. I want you to see, have a very close look at this X-ray abdomen of a newborn. You can see a lot of gas. You can see a lot of air and gas mixture, and there is air within the wall of the bowel, which is called as pneumatosis intestinalis. Now, whenever you get that, you look for portal vein gas, because next thing will happen that it will be carried to the portal vein, or it can perforate, giving rise to free gas under diaphragm. So this is typically seen in necrotizing enterocolitis. Common disease of premature and low birth weight babies, but occasionally you can get it in a full term baby, occasional weight baby also. Key factors are impaired gut barrier, early feeding is started, or hyperosmolar formulas or medications are given. Infectious agent being bifidobacter, and in formula fed babies, E. coli or bacteroides. Pre-surgery, there has to be good optimization of the patient by treatment of shock with IV fluids and broad spectrum antibiotics, correction of coagulopathy, giving vitamin K, fresh frozen plasma when required, so as to achieve a good mean arterial pressure and good urine output pre-op. And then in this X-ray, you can see that it is a NEC resulted into a perforation with a lot of free gas under diaphragm. So much of gas, either colonic perforation or stomach. Stomach is not involved usually in NEC, so this is a baby with colonic perforation and also ileal ischemia. So this baby underwent surgery, and because of poor contamination and poor general condition of the patient, stoma had to be done. The gangrenous part of the bowel and perforated segments were resected, and a stoma was done. As the baby recovered in 2 weeks, the stoma was closed. So how do we decide in a NEC what is to be done? So if the general condition is poor and the abdomen is very badly contaminated, not good blood supply of the bowel, we will do a proximal stoma, or we can just clip and drop if the baby is very, very unstable. Just clip the portions which are non-viable, take them out, and drop the rest, and just close the abdomen temporarily and go in again within a short time, say 48 hours or 3 days, and see how the abdomen has responded to the treatment that you have started. So occasionally the baby is so sick that we initially just put a bedside glove drain into the abdominal cavity and allow the neonatologist to, resuscitate the baby so that it comes to a stage where we can operate for say 1.5 to 2 hours to deal with the pathology. Many of the times we are supposed to do stoma instead of any primary anastomosis because of bad contamination, and then we go in again after 2-3 weeks to close the stoma. This is a very unusual kind of intestinal obstruction. Nobody has. It is said that first temperature should be taken as rectal temperature so that you don't miss a anorectal malformation. But with the use of digital thermometers and things like that, this baby was missed to have missed to have no anus here, and associated. They took an X-ray thinking that it is intestinal obstruction. You can see a big sigmoid level, and then we do an invertogram to see whether it is lateral prone shoot through X-ray, not an invertogram, lateral prone shoot through X-ray. You can see the baby is made prone on a cotton roll, big cotton roll, and you can see the air which is going just very, very distally, very close to the neoanal side. And by this time, the baby had become almost 36 hours old, full-term baby. And you can see a speck of meconium and stool that is stained there. It was a bucket handle type of low ARM. And hence, primary anoplasty just treats the baby and has a very good outcome. So when do we do colostomy in babies with anorectal malformation? So boys with urethral fistula, rectourethral fistula, and agenesis of the rectum and anus, we are supposed to do colostomy. Some of the surgeons nowadays they do primary repair of these babies, but it is some of them can get complications because of neurogenic bladder involvement, because the nerves at this age are very, very close to the rectum when we are mobilizing the rectum. However, in a female baby, low type of anorectal malformation, where there is a vestibular fistula, there is absent anus, but the anus is opening within the rectum is opening within the vestibule, and these babies are deflating right from birth. And they can be managed without any surgery in the neonatal period. And when the baby is around 5 kg or 2 to 3 months old, we can do a good bowel preparation and a primary pull through to create the neoanus. This is a severe anomaly in a female baby where there is only a single opening. And through this opening, if you do the scopy, you will see urethral, vaginal, and rectal opening. This is an anomaly called as cloaca. Here, depending on the level, how much is the common channel, less than 3 centimeters, more than 3 centimeters, whether vagina is adequate in length or not. Better to do a transverse colostomy because you may use the sigmoid for creation of the vagina. So these babies undergo a colostomy. Now we come to delayed passage of meconium. Usually full-term babies pass within 24 hours, whereas preterms they tend to pass little late by 48 hours or so, or little later as well. The babies are not able to pass even gas occasionally, depending on the length of the aganglionosis, and some of them may, after stimulation, pass a meconium plug, not all. So delayed passage of meconium, bilious vomiting, abdominal distension, X-ray has been taken, and you can see lot of gas-filled loops, and there is no gas in the bony pelvis. There is nothing, completely nothing. That suggests you when you do a rectal examination, the anus and rectum is gripping your finger tightly, and as you withdraw, there is explosive passage of gas as you enter, overcome the resistance of aganglionic internal sphincter. So this is a dye study which is done. This was same slide which we have seen, and you can see that aganglionic rectum and sigmoid and descending, and you can see the coning in the splenic flexure. Okay, so if you can adequately deflate them for a few days or few weeks, then a primary endoanal pull through is done without a colostomy. And if you cannot deflate them, then you will do a colostomy and then a definitive pull through. Thank you.
Thank you, ma'am, for this wonderful presentation. Now I would like to now we move to next presentation. Now our next presenter is Dr. Amrish Vaidya, sir. He'll be speaking on common problems in pediatric urology. Sir is a consultant pediatric surgeon in SRCC hospital, and he's also attached to multiple hospitals in Mumbai. His specialty is pediatric urology and complex cases, urological cases.
Set up the audio. Thank you, Manika. I realize that this audience is a mixed audience of family practitioners and pediatricians and pediatric surgeons. So while pediatric surgery is very challenging for its extremely complex patients, there is also a role for discussing some of the common problems that you might see in your office practice in pediatric urology. Now, we all know the Hindu story of the Gita, where Krishna reveals his Virat Swarup, where in one individual the whole universe could be seen. In a similar vein, I had seen a patient many years ago who is like a Virat Swarup of pediatric urology, because 75% of the common problems in pediatric urology that we've seen are there in this one patient. And let's sit down to discussing what this is. So this is a 3-month-old baby who has come with a large swelling in the right groin. this child has also got a deformity of the penis. And on examination of this child has a large right inguinal hernia. He had a right-sided undescended testes as well as a proximal hypospadias. So the complaints were swelling in the right inguinal region, more prominent while crying. The right testes is not palpable in the hernial sac, and there is a penoscrotal hypospadias. So we are talking about the priorities now. What should we be doing in this patient? Should anything be done in such a small baby? Should the hernia be operated? Should the hypospadias be corrected? Shouldn't the undescended testes be brought down? And are any other investigations required for this child? So let's isolate the problems. There is a right inguinal swelling, there is an undescended testes, and there's a hypospadias. So the inguinal swelling, the first question we need to ask is the swelling a hernia or a hydrocele? And can it be anything else? Now, a hernia is a protrusion of an organ or a tissue through an abnormal opening in the abdominal wall, whereas a hydrocele is a collection of fluid around the testicle. In the first picture, you see a large right-sided inguinal hernia. In the second picture, you see what is called an encysted hydrocele of the cord on the left side. Now, both a hernia and a hydrocele are because of a patent processus vaginalis. The processus vaginalis is an extension of the peritoneum that travels down into the scrotum with the testes. And if this is widely patent, then abdominal viscera or structures like omentum or intestine can enter this processus vaginalis, and that is called a hernia. But if the opening in the processus vaginalis is very small, then only peritoneal fluid can pass through, and we call this a hydrocele. So this is a diagrammatic representation of the first one, which is normal. In the second one, there is a wide opening. So this is an inguinal hernia. If the processus vaginalis is open all the way down and the hernia goes down and envelopes the testes, it's a complete inguinal hernia. If there is a very small opening and an isolated part of the processus vaginalis is open, we call it a hydrocele of the cord. And if there is an opening which allows fluid to enter back and forth, we call it a communicating hydrocele. Now, the hernias, the overall incidence is 1 to 5%, and the age is higher during the first year of life, highest in premature patients. The peak incidence is in the first month of life, and the male to female ratio is 8 to 10 is to 1. Now, this is natural because in the male, the testes descends down, and so the chances of having a processus vaginalis, which is patent, are much higher. It is more common bilaterally in females and also in premature patients. In this picture, you see a child, a female child with a groin swelling on both sides. This is a female with a bilateral inguinal hernia. Now, a groin bulge which extends towards the top of the scrotum or the labia, which is visible most frequently during periods of increasing abdominal pressure, are diagnostic of a hernia. It is caused by crying, not generally symptomatic. The diagnosis of an infant hernia is made on the basis of a history provided by the parent or pediatrician and by the physical examination. Excessive crying, irritability, and a fixed groin swelling points to a complicated hernia. So on examination in a hernia, you will find a groin scrotal or a labial bulge. This swelling increases on straining, coughing, crying, or standing. It is generally reducible. You can push the hernia back with pressure. If the hernia is reduced, you can see what is known as a silk glove sign. If you run your finger against the cord structures, you can feel a kind of sensation as if there is a double layered, very fine membrane present there. Sometimes the only thing that is felt is a thickened cord. But at times, if the hernia is complicated, then it may be irreducible. And an obstructed hernia is a hernia with signs and symptoms of intestinal obstruction. If the hernia is strangulated, then you can find a red, angry testicular enlargement as well. In female, there is a labial bulge. There is generally a palpable gonad. And in 1 in 1,000 cases, a hernia is diagnostic of a complete androgen insensitivity syndrome, and we'll come to that a little later. A hydrocele is a collection, as we said, of fluid. This is just a collection of peritoneal fluid in the tunica vaginalis, and generally hydroceles are not reducible. So the presentation of a hydrocele is a swelling in the scrotum, a fluctuation in the size of the swelling. What the parents will report is that the swelling is more in the evening after the child has been active, and early in the morning when the child wakes up, because of the recumbent position and relaxation, the hydrocele seems smaller. A hydrocele is not characterized by sudden appearance and disappearance. It's not related to crying and is otherwise asymptomatic. One of the important signs to look for is a transillumination of the scrotal swelling, because there is a differential diagnosis if the swelling is not transilluminant. So the management of hernias. In hernias, there is no place for conservative management since a hernia can complicate. Delay can result in the loss of the testes or ovary or a portion of the bowel if incarceration or strangulation occur. An inguinal hernia will never cure itself spontaneously and has to have surgery done. It's performed usually as an outpatient procedure under general anesthesia, also using regional anesthesia, which has made anesthesia for conditions like hernias extremely safe. A hernia can also be tackled laparoscopically, but the jury is still out on whether this is the best method or not. The time of admission is the same, operative time is more or less the same. I think the complication rates are, again, more or less equal. One of the advantages cited for a laparoscopic repair of hernia is that the scars are smaller and less visible. But in front of you, you see a patient who has had a right inguinal herniatomy done. And I think anyone would have to look very hard to see a scar in this patient. So generally, scars of hernias heal very well. In fact, if you do an open herniatomy, the anesthesia required is much less than the anesthesia required for a laparoscopy. And the other advantage is that you don't have to go past the intestines and past the intra-abdominal viscera. All your operation is being done under the skin and subcutaneous tissue. So I prefer a normal open herniatomy, though others may prefer a laparoscopy. Investigations in unusual cases and ultrasound is useful. Otherwise, it is a clinical diagnosis. In females with palpable gonads, where there is a rare chance of a complete androgen insensitivity syndrome, I prefer to have an ultrasound of the pelvis done. And if a normal uterus can be seen, then this condition is ruled out. In the past, we used to do a bar body test or a vaginoscopy, but I think with good ultrasound machines and good reporting, this is no longer required. So we are isolating the problem. There is an inguinal swelling, which is either a hernia or a hydrocele. Well, could it be anything else? Yes, it could be something else. In the patient on the left, you see someone with a large, angry looking swelling in the groin. And this is something that you wonder, is this a strangulated hernia? But no, this turned out to be just an abscess. On the right side, you see someone with a scrotal enlargement. On the face of it seems like a hydrocele, but this swelling was not transilluminant and turned out to be a testicular tumor. So doing a transillumination test or having an ultrasound report is extremely important before a scrotal swelling is termed a hydrocele. So now we come back to our case. Our case has a swelling in the right inguinal region, more prominent while crying. So we know that the swelling is a hernia. The management is surgery. And the next problem that we have in this case is an undescended testes. Now, an undescended testes is a defect where the testes fails to descend completely in the scrotum, also called cryptorchidism, which means basically a hidden testes. It's present in about 3% of full-term male newborns and in 33% of preterms. The incidence is 1% at 1 year. So the descent of the testes takes place mostly in the months just before birth, and sometimes this process can continue after birth up to about 6 months, but no longer than 6 months. The causes of an empty scrotum are an undescended testes. There's another condition called an ectopic testes. It could be a retractile testes. It can be anorchia, where this testes has not formed at all. There is no testes present, or the testes can be atrophic. Now, an undescended versus an ectopic testes. An undescended testes is generally a testes which is undescended in the line of descent, where the testes is supposed to come down via the cord structures into the scrotum. That is an undescended testes. Whereas an ectopic testes is a testes which has lost its way. You see that patient on the right-hand side where the testes was found in the pubis. This is called a pre-pubic testes. This is clearly not anywhere close to the line of descent, but the testes seems to have gone in another direction. So an ectopic testes is misdirected outside the normal path of descent below the external ring. The most common location for an ectopic testes is the superficial inguinal pouch, which is right next to the testes. So what do you do when there is a hernia with cryptorchidism? In the patient on the left, which is our patient, it's a classical inguinal hernia with an undescended testes. Whereas in the patient on the right, you can see that this testes has gone outside the scrotum. So this is a hernia in an ectopic testes. Now, we have the one thing that we need to differentiate is a retractile versus an undescended testes. So retractile testes is something which is found in the scrotum sometimes, especially when the baby is fast asleep. It can be manipulated from the retracted position back to the scrotum, and the scrotal pouch is seen to be well developed and the same as the pouch on the opposite side, and no treatment is required in a vast majority of cases of retractile testes. Whereas an undescended testes is not found in the scrotum at any time, and you will see that the scrotal pouch on that side is hypoplastic and flat, and this patient will need surgery. The best way of getting a retractile testes back into the scrotum is to examine this child in the supine position or in the seated cross-legged position or in the squatting position. Both these positions tend to bring the testes back to the scrotum. Else the parents should be asked to observe the child while he is asleep. And generally when the child is asleep and relaxed, the testes will come back to the scrotum. The consequences of an undescended testes can be infertility. There is always an associated hernia. Undescended testes are more prone to trauma because the scrotum is one of the most protected places on the body. An undescended testes is prone to torsion. If there is a right iliac fossa pain with an empty scrotum, the diagnosis is more likely to be torsion in an undescended testes than an appendix. And the testes, which is undescended, has a higher chance than a normal male of undergoing becoming cancerous. It is believed that early orchiopexy may decrease the chance of a malignancy in an undescended testes. So the management is clearly orchidopexy with a success rate of more than 95%. And the ideal age is between 6 months to 10 months, but definitely before 1 year of age. The indications of treatment less than 6 months are if the undescended testes is present with the man.
इकडे या ओ ताई
Will someone please switch off?
काढला का ECG
Will someone please switch off their mic? We can hear you talking.
उधर सामने सिस्टर बैठे ना उनको बोलो उनको बुलाने
Dr. Pratiksha
उनको
Wadekar.
वो ECG वालों को बुलाओ बोलो उधर
Dr. Wadekar, can you please switch off your mic? Dr. Wadekar, we can hear you talking. Please switch off your mic. So the success.
Sir, kindly unmute yourself.
Am I audible now? Yeah. Yeah. The one thing that you have to treat with caution is an undescended testes with a hypospadias that we have in our patient. Because though a normal undescended testes is okay, though a normal simple hypospadias is okay, an undescended testes with a hypospadias should ring alarm bells. Now, what can happen for an undescended testes with a hypospadias? So here was a 14-year-old child with a well-developed phallus, but with a hypospadiac urethra, and with one testis descended and one testis not descended. When we look at him in the perineum, can you see that little pit which is seen just behind the scrotum? That's a very important diagnostic sign. And when we did an ultrasound on this child, we found that there was a pencil-like tubular structure behind the bladder. And when we did a cystoscopy or a genitoscopy, we could see something like a vagina entering into that space where the urethra normally enters. And when this child's karyotyping was done, he had a mixed karyotype. And these are the children who have conditions which are called disorders of sexual uh, differentiation. So in this child, the hypospadias correction was done with an exploration to remove the hemiuterus tube and the gonad on that side, and by doing a testicular biopsy. And on the left side, we confirmed that he had a testes. On the right side, he had what was called a streak gonad, and his condition was something called a mixed gonadal dysgenesis. This is a former diagnosis of this condition. These days, we call it XOXY DSD. And if we had not removed that streak gonad, then this child would have been prone to cancerous degeneration of that streak gonad. Again, a consequence of not investigating is this child who came much, much later with bilateral gynecomastia and classic cyclical hematuria. This child had what was called a true hermaphroditism, where there is an ovarian tissue and a testicular tissue, and not investigating these children at birth can lead to consequences like this. So again, coming back to our case, we said that the hernia needs early surgery. The undescended testes, since it is associated with a hernia, needs early fixation, and the sex needs determination. So we would like to do an ultrasound of the pelvis for the Mullerian structures. We would like to do a karyotype. And while we do an orchidopexy, we would like to do a testicular biopsy. And then what about the hypospadias? Now, most cases of hypospadias have their surgery around 1 year and can have a one-stage correction. However, two-stage repair may be necessary for some. In some cases where we have something called a penoscrotal transposition or a stall scrotum, we can do surgery earlier than 1 year because we can do something that will bring the penis out in the open, which looks a lot more normal when parents are sometimes changing the child in front of other people. And then a second stage surgery can be done at a later stage. Also, in a case of proximal hypospadias, it is important not only to do an ultrasound of the pelvis, but also an ultrasound of the kidney, ureter, and bladder of the renal system, because renal anomalies are common with proximal hypospadias. And in our patient, this ultrasound showed that there was a left hydroureteronephrosis. Both the kidney and the ureter were swollen, and this is something that we have to keep in mind for further investigations. We did send a blood for a karyotype, and that was a normal 46XY. An early surgery was done for the hernia and the undescended testes. And on a testicular biopsy of the gonad, the testes is confirmed. So two of the problems of the three that we have seen are sorted out. But in investigating the third problem, that is the hypospadias, we have found another problem, which is the hydroureteronephrosis. Now, because this child has a hydroureteronephrosis, it's important to do an MCU because this child may have reflux. So 1 month after surgery, under antibiotic cover, an MCU was done. And this MCU showed that there was a grade 5 reflux on the left side, the side that had the hydroureteronephrosis. And on the right side, there was a lesser degree of reflux, say something like a grade 2 to 3 reflux. The urethra was normal, and this is where we stand in this particular case. So now one more issue has got added on to our diagnosis. And the question is, are we going to do any more tests? Yes, we want to do a DMSA scan. A DMSA scan tells us what the functioning parenchyma of the kidney is like. And it is something where we pick up not only the function, but the health of the renal parenchyma. And in our case, this left kidney, which has a gross reflux, the kidney function is about 35%, and there are scars in the kidneys. The right kidney function is 65%, and there are no scars. So the right kidney is fine. The left kidney is a kidney which was abnormal to start with. And this is where we stand in this case with reflux. Now, coming back to what reflux is an abnormal reverse flow of urine from the bladder into the upper urinary tract. And this is generally due to incompetence of the uretrovesical junction. We call a reflux primary reflux when there is a congenital deficiency in the formation or in the maturation of the uretrovesical junction in the absence of any other predisposing pathology. Sometimes we see a laterally placed orifice here. It might be gaping, or it might lack what we call a submucosal tunnel, which is the support structure of the ureter within the bladder. A secondary reflux, on the other hand, is a reflux which happens because of other urinary tract abnormalities which cause high pressure in the bladder, leading to decompensation of the uretrovesical junction. And such cases are seen in voiding dysfunction, in neurogenic bladders, in obstructions like posterior urethral valves, or sometimes with infection. So what is the incidence of a reflux? When there is a history of a febrile urinary tract infection, the incidence of reflux becomes about 20 to 50% in these children. The age is more in younger age groups. Siblings have a 40% risk if another sibling has VUR, especially if an older sibling has VUR. And associated abnormalities like posterior urethral valves, duplications, or extrophy should be ruled out. Now, the reason for doing an MCU besides the diagnosis of reflux is diagnosing how severe the reflux is. And a reflux is graded in 5 different grades. These grades are important to us because not only can we prognosticate how these refluxes are going to behave, but we can plan our treatment for reflux accordingly. Now, the lower grades of reflux can undergo spontaneous resolution. There is a good chance, whereas the higher grades of reflux have a much smaller chance of undergoing spontaneous resolution and may require some treatment. Reflux is something that we are worried about because it can affect the kidney, and a condition called reflux nephropathy is present when there is a triad of vesico-ureteric reflux, renal scarring, and hypertension. This can occur because of an untreated reflux over a very long time, or a primary poorly formed kidney with reflux, which leads to all this. So what are the treatment options that we have for reflux? First of all, the treatment that is done is always conservative. We put these children on prophylactic antibiotics because we know that reflux, when it occurs by itself without infection, is not bad. A child can live with sterile reflux, as we call it. But if there is a urinary tract infection with reflux, then it can potentially cause scars in the kidneys and lead to reflux nephropathy. Now, this is a double-edged thing because when a child has reflux, he is more prone to urinary infections. And if a child has infected reflux, then it affects the kidneys. So our primary aim when we do conservative treatment is to take all possible measures of preventing urinary infection. And the two main measures in males are prophylactic antibiotics and circumcision, and in females, prophylactic antibiotics and extra care that this child is not constipated. Because constipation is also another risk factor in urinary infection. The reason we do conservative treatment is that all children with reflux have a chance by up to the age of 4 or 5 years of having a spontaneous resolution to the reflux. And if we can keep this child infection-free during that period, then we can give nature a chance to resolve the reflux by itself. However, if the child has what we call breakthrough infections in spite of all these measures, then we opt to to perform some kind of treatment. And this interventional treatment is either an endoscopic treatment, which is the injection of a polymer, which was earlier called deflux, but now something called Dexel is available. In the lower grades of reflux, when this is injected close to the ureteric orifice, as you can see on the small picture on the right, where the injection has been done around the orifice, then this has a good chance of resolving the reflux. However, the final and ultimate treatment is ureteric reimplantation. The indications of surgery or intervention, as I said, are breakthrough infections, which can be because of medical non-compliance and the persistence of reflux into puberty, especially for females, where during pregnancy, these children can get pyelonephritis in pregnancy, and this can complicate pregnancies. So we like all female children to be reflux-free before they achieve puberty. The results of success are very high. They are more than 95%. We come back to our child. What did we do? We gave this child prophylactic antibiotics, which was amoxicillin at 15 milligrams per kg per day. At 1 year, we did a genitogram and there was no vaginal pouch. We know that the testes is normal. We have repaired the undescended testes. The other side testes is normal. So single stage surgery was done for the hypospadias. We kept this child under follow-up for the vesicoureteric reflux. So we continued antibiotic prophylaxis. Amoxicillin or cephalexin can be given in newborn children, but after the child is a few months old, then trimethoprim at 1 to 2 milligrams per kg per day is the drug of choice. But in this child at 2.5 years, we did a repeat MCU, and we found that the right side reflux had downgraded from grade 3 to grade 2, but the left reflux had no change. Now, considering the fact that the grade 5 reflux had stayed where it was, we offered an interventional treatment to this patient, and a ureteric reimplantation was done at 3 years. And as in many, many cases of pediatric surgery, the long-term results were good. This child did not have any further deterioration of the right kidney. The left kidney continued to be poor, but this child never had hypertension. This child had a hypospadias that was repaired, and we are waiting for him to get into the adult age. Some patients actually do come back and report that they have normal relationships and that they have also fathered children. So we are waiting for a happy ending on this child. So here in one child, we have covered at least 60 to 70% of what we commonly see in pediatric urology. And it is amazing how one case can have so many lessons for all of us. Thank you very much. Are there questions from anybody? Okay, thank you very much. We'll go to the next speaker, whom Dr. Manika will introduce.
Our next speaker is Dr. Sowbir. Our next speaker is Dr. Sowbir. He is doing fellowship in pediatric surgery minimal access surgery in SRCC. So his topic is a, a surgical audit of minimally invasive surgery at SRCC Children's Hospital. I'll hand over.
Hi, good evening, everybody. So the topic for the day is an audit of minimal invasive surgery at SRCC Children Hospital in Bombay since its inception. So Hi, good evening, everybody. The topic for today is an audit of the minimal invasive surgery at SRCC Children Hospital. So I'm Dr. Sowbir, a fellow in minimal invasive pediatric surgery under Dr. Rasiklal Shah sir, who is a pioneer in the field of minimal invasive pediatric surgery since 1997 in Bombay and India. So why minimal invasive pediatric surgery? So there are the potential benefits, as we know of from the adult, there's a less post-operative pain and there is a rapid recovery. There is also lesser wound complications, which means there's a shorter hospital stay, and the cosmetic advantages, they're amazing. The other thing that is for the surgeon is the visualization and the magnification. You can visualize anatomy very perfectly, and it also revolutionized the management of undescended testes. As you can see, the testes are non-palpable testes. You just put a scope through, you can find it. It is present just in front of the inguinal canal. You can do a single stage. If it is there farther away, you can plan for it and make a double stage. It's also there in the case of a Hirschsprung disease, where with the diagnostic laparoscopy, you can actually check for the tapering point of it. And from there, you can either go for a multiple biopsies, a colostomy, or a single stage with a frozen section. So the minimal access children surgery, a 5-year study, a lot of people have this idea of why do we want it? So a study conducted in a fellow corporate hospital in New Delhi, they said that all the parents of 211 patient children operated over a period of 5 years from 2012 to 2017 preferred the cosmetic outcome of a minimal invasive surgery. So what are the problems that we have? The spatial discrepancies in a laparoscopic. In case of an appendectomy, as you can see in an adult, there is a larger peritoneal cavity, there's a wider viewing angle, and there is a greater instrument range. Whereas in a child, the peritoneal cavity is small, the viewing angle is narrow, and therefore restricted working space. So to overcome all these, from the adult of 12 mm adult instruments, we have gone to the pediatric micro, or they call it micro 3 mm instruments. The problem with these instruments and everything is, with the time and the effort, the beginning is always slow in increasing your proficiency and skill. There is a steep learning curve, then there is a plateau, and then as you practice more and more and you give the option of minimal invasive surgery, you become a master of it. So the potential hazards, none that I can think of other than the fact there's a carbon dioxide absorption from the surgical cavity. So in an adult, whenever there's a pneumoperitoneum, in an adult case, it takes 10 to 15 minutes for the carbon dioxide that has been absorbed to just get taken out by the inhaling lungs, inhale and exhale of the lungs. In the children case, it just keeps on exhaling. The plateau stage is probably never reached. So the problem of this is it belongs to the acidosis and the potential hazards of the metabolic part. So along with all the parts that we said about the steep learning curve, this ergonomics also forms a part of it. Since the peritoneal cavity is very small and you're working in a very constricted visual angle with the minimal instruments, you need to be ergonomically fit, ergonomically stable to have a fit so that your arms and shoulders do not get a lot of strain. So you need to have the instruments at the elbow level between an elbow flexion of 90 to 120, the table at a range of 64 to 77, and the monitor definitely below the visual angle. It saves you from the neck pain. Then comes the ergonomics of triangulation. So if you have a target organ, like in an adults, everything is almost predefined because the range you do not kind of see. But in an children case, you have to have the total ergonomic part where you have to triangulate the whole thing. So the optical port, if it's in the umbilical area and your target organ is there, you have to put up the ports in such a way that you get a minimum of a 60-degree angle in the working part. In cases of specific organs like appendix, we do a sectorization of the ports where the working ports are put in a single sector. The problem of this is if you have to deal with any other part of it, say along with this, there's a liver abscess. So dealing with the liver abscess in a laparoscopic way might be a little difficult, but to deal with the appendix, this is one of the best and the easiest, fastest possible way. So brief history. Since in India, the first laparoscopic transanal pull-through was done by Dr. Rasiklal Shah sir in a 1-year-old girl, and this was presented in 1999 in the IAPS section of minimal invasive surgery. So since 2017, I tried to find out all the various types of minimal invasive surgery done, the number of patients, the complications, and the conversions of laparoscopic, vesicoscopic, thoracoscopic procedures. So 1,426 minimal invasive surgeries were done till October 2025. Out of them, 40% were endourological procedures, 45% laparoscopic, and 10% thoracoscopic. In the 32 endoscopic procedures also included 5 endoscopic emergency procedures, including a foreign body for them in the bronchus. In the laparoscopic section, we had 197 appendicectomy, 167 inguinal hernia repair, 71 diagnostics, 4 emergency. In the appendix, 197 of them done, 45 of them were emergency, and 5 of them were unfortunately converted. So as you can see in this, we can find a pus-filled appendix, and it's just beautifully seen. There is no contamination, nothing. You just separate it. You just see the gap, separate the mesoappendix, take an endo loop, and just ligate it. Yeah, very carefully done so that there is this appendicular stump is kept as small as possible, and the cecum is also not taken in the suture. It's taken to suture to prevent any spillage. 2 endo loops are used, and it is just taken out of it in a glove. So in the other part, 13 laparoscopic cholecystectomy, choledochal cyst excision were done in 33 of them, fundoplitis in 27, which we had recently discussed, laparoscopic assisted pull-through 33, Kasai for the extrahepatic biliary atresia, along with intraoperative cholangiogram in 11 patients, drumstick pyloromyotomy in 15 of them, intussusception 3, splenectomy, duodenal atresia, and colonic duplications were also done. Here, as we can see, the small case of a laparoscopic cholecystectomy, we are very familiar with the Kellogg's triangle. The Kellogg's triangle is beautifully dissected. You can find the cystic artery, which is just bipole and cut, and then we just ligated the cystic duct along with it. In the inguinal hernia, 167 inguinal hernias. And you can see that in a laparoscopic section, it does not only give a benefit of not touching the vas and the vessels, but also you can see the contralateral side of it. And sometimes these are the hernias in the contralateral sides where the ring is open and we just miss it in the clinical way. Obviously, there is no role of doing an ultrasound in a inguinal hernia. So as you can see here in the ergonomics part, the vas and the vessels are definitely not touched. So infertility, it is definitely not a case of laparoscopic surgery that is the problem thing. So the sac is dissected out beautifully, and then it is excised, and the peritoneal internal opening that is there, a vicral suture is taken off, and then the ring is closed properly. Recurrence level in this so far right now has been only 1 case out of 167 of them. And this is just closed. So bilateral adrenalectomy, 4 of them are done, pancreatic pseudocyst 4, and thymectomy 1. The ovarian pathologies, very common in this area, 30 of them are operated, including 3 for torsion, and gonadectomy were done in 7 of them. So here we have a ovarian cyst. As you can see, the cyst is the para-ovarian cyst. The right ovary is there, and the para-ovarian cyst, it is being dissected out meticulously, keeping the right ovary intact. The cystic fluid was just drained, taking minimum care for the vessel, taking care for the vessels, the fallopian tube, and the ovary. Everything is kept intact. This is the para-ovarian cyst, which has been dissected out beautifully. In the endourological procedures, we have done 124 orchidopexies, 115 pyeloplasties. Posterior urethral valve were ablated in 122 of them, nephrectomy in 18, ring plantation in 23, including 14 vesicoscopics. So here we can see a small thing of a non-palpable undescended testes Upon diagnostic laparoscopy, we could see that it is just lying in front of the inguinal canal. We just checked it. If it is reaching the pubic symphysis, it is definitely reaching the pubic symphysis with a little bit of a dissection. It can just in a single stage pull down to the inguinal area. In case of a PUV, here as you can see, there is a PUV which is seen. The bladder looks normal almost, the ureteric channel and orifices. And there is the PUV at 12 and 7. We take a Bugby here, and along with the Bugby, with a steady hands, we just, at 12 o'clock, we just ablate the valves. So the most important thing here is to take care that you do not overdo the whole thing so that it can damage the urethra also. So as you can see, it is done in a very controlled way, excellent vision, excellent control. And the children, after Foley's for 1 to 2 days, they just go home. And the procedure is just a life-saving part from developing a neurogenic bladder. So 12 o'clock, along with the Bugby, it is just ablated the valve. So in case of a pyeloplasty, which has been done, as you can see for a posterior urethral valve narrowing, as you can see, this is a right-sided kidney. You can see the ureter, you can see the pelvis in a normal shape, and there is a kinking of it. We're taking a lower pole with suture, and then we just pull it up. You can definitely appreciate the narrowing of it and the peristalsis that is coming from the ureter. We just cut it open. The ureter, you can see the narrowing part of it. The lower pelvis part is cut. Made sure the fact that the anastomosis that is going to be done in a wide one. The ureterotomy is done from the normal section. It is taken without handling any part of the ureter. The ureter is here not damaged, and therefore the vascular supply of the ureter is well maintained. So it is sutured here and then along with the DJ slope. So as you could see the normal shape of the kidney, here we see a malrotated kidney. As you can appreciate that the pelvis is there at the 12 o'clock level. So in this position where the conversion rates are higher, we have just taken a stay suture, and there is the pelvis, and that is a very beautiful appreciation of the anatomy of a malrotated kidney. So we have taken the same principles are followed. A stay hip suture has been taken, the pelvis has been cut, the ureter is not touched, the narrowed portion is cut, a ureterotomy is done, and then a stay the suturing has been done in the posterior layer first, along with the vitral, and then after the completion of the posterior layer, the DJ stent has been put, and again, the pelvis has been closed. So the child went home on the 5th day after the drain was taken out. So in case of a vesicoscopic, this is a lasso technique that we have come across, a new and innovative technique in taking the ports in a case of a vesicoscopic part. As you can see, one loop, we have taken a thread from the ethylon and passed through it, another of the loop, and then we are taking the loop section out of it so that the anterior bladder wall that is getting hitched to the anterior abdominal wall. So as you can see here, the first taken is out and then the second part. So after this, we have excellent view of it, the vesicoscopic. So what I want you to appreciate in this child is that it is just a 6 months old child. And this is the working space that we have to do a ureteric implantation. So this is the right ureter, very carefully dissected to preserve its blood supply. And then comes on the left side, same approach, very careful dissection so as to preserve. So you can appreciate that from a normal open surgical procedure, you can actually see the blood vessels, and this helps in preserving the anatomy of it. So a submucosal tunnel has been created to make sure the fact it is actually a submucosal and we do not go inside the musculature of the bladder. So submucosal tunnel is being created, and along with the creation of the tunnel, we are taking the Cohen's ureteric reimplantation. The left increases in the length, and it comes out to the right side of it. And then the same procedure is done for the left side, which submucosal tunnel is again created, which is again creating to the left-hand part of it. So in this, as you can see, the only working area that we are doing it is just in the bladder. You can check if the bladder, the damage to the bladder wall and the bladder mucosa in a case of minimal invasive surgeries are the minimal most. The child went home after 6 days, and thus an extra length has been created for the VUR. So this is the Cohen's ureteric reimplantation that has been done. So in case of a thoracoscopic part, an empyema and decortication, lobectomy, TEF repair, plication of the diaphragm, CD, congenital diaphragmatic hernia repair, and mediastinal ganglioneuroma has been also operated. Here we can see a case of empyema of the thorax, where we took up the patient for decortication, and you can appreciate the pus that is present there and how much difficulty are we having in going for the space. So in this area, you just have to be patient. You have to make yourself comfortable. The ergonomics is super important in this area. So are the port positions, and along with it, you just have to take up each and every minute by minute, all the pus has to be evacuated. In case of a TEF repair, you can see the azygous vein. And that the only problem that you have in this is the lungs. So again, I want you to appreciate the area of work, the working channels and the working port are the most important area where the working places are there. So the lower pouch has been dissected off, and you can see the lower pouch along with the fistula that you can see below. So in this case, the upper pouch is being dissected throughout. So we are keeping the azygous vein intact out here and dissecting out. So the vagus nerve here and thoracic duct and also this lymph, everything is preserved. So in case of a CDH, you can see the gap that is being there. So you can see the lung, and there is an anterolateral defect of it. So the intestinal components are pushed down. The thinning of the diaphragmatic tissue is there, and it starts from the medial border of it, taking 80.20. So excellent vision. You can see that like the diaphragmatic part that is there. So you just close it one by one, and again in the lateral part of it, you take it through the ribs. You take the ethibond suture out, and then again you take it out through the skin level. In the skin level, you just close it so that you do not get any suture material or anything. So this is how it looks after the diaphragmatic repair of a congenital diaphragmatic repair. In the pediatric surgical oncology, so the general consideration should be that you should avoid spill, there should be an R0 resection, the specimen should be intact, and it should be organ sparing, and optimal lymph node sampling should be done. So there has always been a controversy surrounding the question whether the high fidelity oncologic resection of childhood cancers can be achieved through MIS. A 2018 study from Nashville, USA says that the current evidence is supporting the efficacy of minimal invasive surgery to accomplish a definitive oncologic resection. So in SRCC, we have operated on more than 35 surgical procedures for including nephrectomy, pelvic mass, ovarian pathology, pelvic component of the sacrocoaxial teratoma, neuroblastoma, and lymph node sampling, and also biopsy. In case of a thoracic ganglioneuroma, you can see the excellent vision that is there. All you need is 2 ports taken in an optimal position. Harmonic instrument is taken, and then the thoracic neuroma is just sliced apart from its tissue. So the esophagus that is lying below, that is not disturbed. Any part of the thoracic duct that is there, nothing is disturbed. There is no injury to any of the organs. So in case of all the children that we have treated in an open thoracotomy And by minimal invasive, we all know how long they take to discharge the open thoracotomy patients. As you can see, we just slice it open, excellent vision through it, lungs are not damaged. All the structures below it, including the nerves, everything is taken care of properly. We take it out, and so this becomes an R0 dissection, and then comes an R0 dissection, and then comes the part where we should give an optimal specimen. Intact specimen should be given without any spill. So there was no spill, and the specimen also was taken out by the Ziploc bag. In case of a thoraco-abdominal ganglioneuroma, we could see that it is there in the thoracic part and just above the diaphragmatic area. So we took a minimal invasive approach from the thoracic part. We dissected it out. The aorta was just lying below. The thoracic duct was also there. We used the endocyanine green to check for any leak out, any damage to the thoracic duct. We packed it in a Ziploc bag and we took it out in a piecemeal way. Yes, some people might have a problem with the piecemeal way, but neuroblastoma, you can take it out in a piecemeal way because taking out a 8 centimeter lesion out in a 8 centimeter incision, that is not to be done. So in case of an ovarian pathology, here we can see that there is a right ovarian tumor or a mass that is there. There is some peritoneal fluid. So respecting the principles of it, the ovarian fluid was taken for sampling. It ultimately showed that malignant cells were found. So the ovarian part was dissected, salpingo-uretrectomy was done along with an omentectomy in the same sitting. Now, this being achievable in an open method would have included a midline scar of more than half of it, 5 centimeter above and 5 centimeter below the umbilical level. So the almost 90% of the omentum was also taken up and it was sent for biopsy. The incision was given through a phalangeal incision and the specimen was taken out intact. In a special circumstances where cosmesis is important, SLET was done for torticollis and fetoscopic 2 surgeries were done. So in a tenotomy position, the head was turned towards the opposite side and the soft bolster was placed underneath. And then this is what you have in the camera entry view. You have the sternocleidomastoid heads for it. You create the space for 3 mm port. You do a subcutaneous plane dissection. And then you just palpate and you feel the sternocleidomastoid head and you dissect the lateral bands of it. You dissect the lateral bands from the head to the internal jugular vein. You always see the contracture, always confirm the bands are present or not. Whenever you feel the bands are present, do a meticulous division of the sternal heads, taking care not to damage the neck structures that are present there. So these are the sternal heads which are fibrosed, which is just taken out through a cautery. So the incision side is where the port insertion is from the axillary side. So you do not have any scar. So you again palpating for the normal contracture, and there you can see the IJV, and then the dissection is properly controlled, completed after all the blue part is taken away. So you have to be very gentle during the dissection as the IJV is just below it. This level of control that is there can be possible in a minimal invasive way where there is an absolute magnification and the visualization in the neck area. So the conversion rate of 1,426 patients with just 3%. So this is available just because of the practice and the mastery of the surgeons that is here. So the instruments are availability of 3 mm instruments and 5 mm instruments in a pediatric part. The awareness of minimal invasive to open are the challenges of it and the education of it, that laser and laparoscopy are definitely two different entities, and laparoscopy has a role in almost all the pediatric surgical cases and laser in only a few of them. Thank you.
Where is my presentation? Good evening, everyone. So I can see 48 participants who are still online. Thank you. As all of you know, we will be completing 7 years. 7 years in of this masterclass. We have started in January 2019, and the 7 years will be completed in December 2025. Thank you for your support. Today, I am going to tell you about why minimal access surgery in pediatric oncosurgery. The reason is not many people do today minimal access surgery in pediatric oncosurgery. Let's go through some of the slides why it should be done, and if we do it, how it should be done. So these are some of the references which we have seen. Why MAPS in oncosurgery? The world is looking to improve the quality of life by administering minimum chemotherapy without compromising results. So there's a lot of research going on after how to reduce chemotherapy, and what is neglected is the surgical part. And today also there are long incisions taken while performing surgery in tumors. There are many small tumors which can be easily done by minimal access, and they go through big incisions, and we need to think over it and offer this access to many of our patients, and that is why this particular talk is. So what long-term survivors want? They don't like to have an unpleasant scar or scars on the body. Scar leads to an emotional distress, a negative impact on their quality of life due to disturbed body image. And there are a lot of studies done to prove this aspect. The advantages of pediatric onco minimal access surgeries are same like any other minimal access surgery. Intraoperatively, there is definite decrease in blood loss, and there is definitely less handling of tissues. There is excellent magnified view of retroperitoneum, hiatus, pelvis, and thoracic inlet. These areas are not easily visualized even in open surgery. So definitely there are a lot of advantages during surgery of doing these surgeries using minimal access. नहीं दिख रहा
ये चल तो रहा है, ये तो है। अच्छा,
Okay, so immediate post-operatively, there is definite decrease in abdominal pain, decrease incidence of pneumonias and atelectasis, decrease in period of paralytic ileus, and early feeding can be started, decrease in the length of hospitalization. And because of all this, we can start chemotherapy early. There are no chances of wound adhesion. This is very important because their nutrition is many times affected and they can have abdominal burst, but all this can be avoided if we do minimal access surgery. Improved immunological response has been shown in additional advantage. Early removal of the drain also can be done as compared to open surgery. Advantage of notes in long term, there is definitely higher incidence of adhesive obstruction after open surgery, which can be avoided. Scar-related psychological issues can be decreased. There is no dysfunction of shoulder or chicken wing scapula or chest wall deformity or scoliosis after doing minimal access surgery as compared to open. I will show you some of the videos just to give you an idea what all can be done. So this was in a small girl functioning adrenocortical carcinoma. And we went ahead and took it out using minimal access pediatric surgery. So what we are doing is mobilizing the left lobe of the right lobe of the liver by dividing the triangular ligament, and then that is what you can see is the adrenal gland or adrenocortical carcinoma. That's the kidney. That's the inferior vena cava. You can see that amount of magnification helps us with the precision. So that's the inferior vena cava. This was a beautiful ligashore instrument, which is very blunt tip, which is unlikely to damage anything. These are the adrenal vessels which are being clipped. So that is being clipped. And then we will continue dissection of inferior vena cava from the adrenal gland to make sure that there are no more blood supply. And while doing this dissection, we will find some vessels which are supplying the adrenal gland. So this is ligashore or bipolar vessel sealing device, beautiful instrument, blunt tip, and it is unlikely to damage anything with the tip, as well as it gives beautiful hemostasis. That is the branch of the phrenic, inferior phrenic, which is supplying the adrenal gland. Yeah. So this was the adrenal branch of the inferior phrenic vessels. So then the tumor was placed in a plastic bag and removed. So if we have to do open, this patient would have needed right subcostal incision, which will be at least 10-12 centimeter in size. And here we could get away with just few centimeter incision. That's the tumor which was removed, about 5 to 6 centimeters in size. This is another patient where the 5-year-old boy presented with thoracic mass. This was a neuroblastoma or ganglioneuroblastoma. It was quite adherent to the lung as well as chest wall. This patient underwent thoracoscopically. Even open surgeries are difficult in these areas, but because of magnification and advanced instrumentation, the surgery becomes easier. So that is the adhesions with the chest wall, which is being dissected off using same bipolar vessel sealing device. It gives very good hemostasis also. And here you can see there will be thickened sympathetic trunk on the medial side, and medially there will be aorta also. That is a sympathetic trunk. The tumor is, we are removing or dissecting off the sympathetic trunk. And medially, there is a aorta. So that's sympathetic trunk, which is thickened. These are the nerve roots which are thickened, which are being divided. So even the tumors which are high in thoracic cavity can be easily removed using minimal excess surgical technique. By doing this, like what Dr. Sowbir said, you can decrease the chance of scoliosis and musculoskeletal problem of large thoracic incision. All that can be avoided. And then you put it in a bag and take it out so that there is no spread. Then some ganglioneuroma can be taken out piecemeal. So this was very large ganglioneuroma, though it was diagnosed as extralobar sequestration, and it was coiled or embolized by the interventional radiologist. It did not improve over 3 years, and the patient came for surgery, and they wanted it to be done by minimal excess and came to us. And the only way we can take it out was by taking it out piecemeal, because otherwise we cannot have vision on the medial side of this large lesion. Initially, it was diagnosed as extralobar sequestration, but while performing the surgery, we realized that it is not sequestration, but it is more likely to be ganglioneuroma, and which was confirmed post-operatively. So bit by bit, we took it out. It took us almost 5-6 hours to complete this surgery. And at the end, we took out almost everything. There was not much of the bleeding because of this beautiful instrument of bipolar vessel sealing device. At the end, very good wash was given. MRI was repeated after 3 months just to make sure there are no spinal extension. So there was no extension, and residual of tumor was less than a centimeter in size. These are benign tumors, and we don't need to worry about anything if it is left behind. Though the child will be kept on surveillance. So this is the last part which is being taken out. So this is little bit which we are still taking it out. At the end, there will be very, very limited amount this is little bit which is left behind. The entire tumor was taken out using minimal excess surgical technique. This is another tricky patient which had thoraco-abdominal ganglioneuroma, and they are not easy. So the dilemma was to approach from the thoracic side or abdominal side. We decided to go by a thoracic approach, and you will see that the entire tumor was taken out very easily. And this was possible because of the minimal excess surgical technique. Otherwise, they are not easy. Yeah, so you can see large tumor, almost 7-8 centimeter by 3-4 centimeter by 3-4 centimeter. So this is how we approach the tumor. This is in the right lower chest. That is the tumor. You can see nicely, that's the tumor. And this is the harmonic scalpel which is being used. So bit by bit, I think Dr. Sowbir also showed this video clip. So I'll just fast run it. So that is being done. This is on the medial aspect, and this part is going below the diaphragm. And once we divided the pleural lining, the tumor by itself, it came into the view. This is the ICG camera which we use to make sure that thoracic duct is not being injured. So that is the diaphragm. You can see nicely the tumor has been taken out completely. That's the diaphragm. We made sure there is no injuries to any important structure, put it in a bag, and then we took it out piecemeal. The end of the bag was taken out from one of the port side, and the tumor was divided into multiple pieces and was removed. Yeah, this is how we take it out. And then I will show you one short video clip of the Wilms tumor. This is the laparoscopic nephrectomy we did for 2-year-old girl who had a Wilms tumor, was being treated with chemo. The size was reduced, and then we went ahead and took out the tumor. So this is again harmonic scalpel. That's the descending colon, which is being reflected. The first thing is the exposure. So we will reflect the colon medially. These are the mesenteric vessels pulsation you can see. These are the renal vessels. This patient had a duplex kidney, which was not reported before surgery. During surgery, we realized that it is a duplex and tumor was originating from the lower pole. So we could have done easily partial nephrectomy or nephron sparing surgery in this patient if it was diagnosed preoperatively. So all these vessels were either clipped with hemlock clip or liga clip, and then one artery we ligated using free tie. This was the artery because there was no space. We decided to ligate it, and we could do that easily. So this is a free ligature which will be ligating these vessels. Vessels will be ligated, and then the rest of the stuff will be divided using either scissors or harmonic scalpel. All other attachment will be divided. So this Wilms tumor, we will make the financial incision to remove it. So cosmetically, it is good, as well as there is less handling of tissue. So there is the period of paralytic ileus is less, and we can start feeding her. We will see 2 ureters. Yeah, and then the rest of the attachment we divided using harmonic scalpel. Then we did lymph node sampling. This is very important to stage the disease. We take out at least lymph nodes from the 5 areas and send it for biopsy. If there is a lymph node involvement, it will upstage the disease. So the lymph node biopsy was taken from the 5 areas. Then the financial incision was taken, and this was removed. So indications includes biopsy of abdominal and thoracic lesion, especially when it is not possible using sonography guidance. Tumors are like neuroblastoma, small lesions, Wilms tumor up to 7-8 centimeter in size, ovarian tumors, teratomas, and other malignancies can be operated. Adrenal tumors, including neuroblastoma, adrenocortical carcinoma, pheochromocytoma, sacrococcygeal teratoma, division of median sacral artery can be performed. Chest tumors, we already show a lot of things can be done. Personally, here we have done few neuroblastomas, pheochromocytoma, adrenocortical carcinoma, Wilms tumor, ovarian dermoid. Thoracoscopically, we have done many neuroblastomas. ganglioneuromas, lung biopsy, other tumors, lymph node biopsy, cyst, etc. So a lot of surgeries can be done using these techniques. There are some objections of using this in oncosurgery, that in neuroblastoma, we need to take out more than 90%, and that can be performed even using minimal access. Unless it is very adherent everywhere, then we may have to do open. So if it is not feasible to do it laparoscopically, one can always convert the surgery into open surgery. If margins are positive in hepatoblastoma or in Wilms tumor, it does not adversely affect long-term survival. Another objection is there is no tactile feedback for the infiltration. But with experience, one can have tactile feedback by instruments. Conversion in difficult case, we always do it because safety is more important, than having problems. Lack of instruments for proper handling can do the rupture, but with gentleness and precision, we can take out most of the surgery like any other open surgery. Chylothorax incidence is similar to thoracotomy. Port site metastasis is rare, especially when you put it in a bag, and that is what is the norm. And there is ongoing study on angiogenesis and metastasis of neuroblastoma due to CO2 exposure. Other objection includes need of single lung ventilation, which is not easy, but today we can do most of the procedure just by CO2 insufflation. And removal of the specimen is always by plastic bag or mini thoracotomy and mini laparotomy. Tumor rupture can upstage the disease, but with gentleness you can avoid it. It can happen even in open surgery, so it is not that only minimal access surgery the tumor rupture will happen. Incomplete nodal sampling is another objection where most of the time you can take it out with by giving some additional time. Personally, I feel today there is a definite role of MAPS in pediatric oncosurgery. There is a need of experience of laparoscopy surgery before venturing into advanced pediatric oncosurgery by MAPS. To start with simple cases and then do more complex surgeries. The case selection has to be done properly. Conversion to open surgery is not a failure. It is a next big step in improving quality of life in pediatric solid tumors. Thank you very much for your patient hearing. If there are any questions, we'll be happy to answer them. Thank you all 43 participants who are still with us. If there are no questions, then we'll call it a day. Once again, thank you all.